missing their patella or their kneecap.
Mm-hmm.
So you have a big joint here where the kneecap glides between
Mhm.
these two. These are two trochlear ridges.
Mhm.
And then the weight is borne down between these femoral condyles and the top of the tibia, and this is where your meniscus is. So, where the injury on your Philly is on the lateral trochlear ridge. So, what you have is the break is right here. So, where the patella slides or glides down, you have this area right here.
Well, let's see. And you said that. Okay, so what am I looking? Isn't it right up in here, up on her hip? Is this the knee area?
This is the knee, yeah.
And so
So this-
she's shaved up here, right?
No, it's here. So this, if you took this part, you would put it right on top of this bone. So their hock.
Oh, okay.
Yeah, so-
All right, it'd be on top of you.
Yeah,
Okay.
their hip joint is up here in their pelvis. So if we look at this skeleton here,
Okay.
this is going to be more her size anyways.
Oh yeah, that's right. It would be right down in here somewhere is where she's shaved.
So it's right here is their joint.
Uh-huh.
So this is the kneecap. So here's their hip joint.
Mhm.
And it's because their femur comes out at such an angle.
Mm-hmm.
So it comes out here, and then, so here's your tibia, and here's your femur and kneecap. So this is right by where their body wall is kind of
Yes,
coming
yes,
up here,
okay.
so their
Mhm.
flank. So their stifle joint is actually a lot higher up than
Mhm.
people think. And then their hock is down here, so you can see the point of the
Mhm.
hock.
Yeah.
And so her break is right here on the outside of this part. So on this one, you can actually see where the patella, this glides up and down here. And so it's this portion here that is broken off. And that's what we're seeing on this x-ray. So on youngsters, these two ridges, the inside one, which is a lot bigger, and the outside one, which is a lot smaller, these trochlear ridges aren't fully calcified or mineralized. So they have this very kind of moth-eaten appearance. So
Just a moth-eaten.
okay, so see all this up here where it looks kind of scraggly and rough?
Yes.
That's normal at this age. So that's something that a lot of people often get wrong when they look at x-rays on these guys, is they look at all this area and say, well, it looks, that would look more like what we would consider like a bone infection, except that in youngsters, that's normal. So if we look at the other knee, we would see the exact same pattern. The
Okay.
thing that's not normal is to have this big piece of bone floating here.
Okay, and that's the thing that you.
That's what we remove,
Okay.
yeah.
Okay. And where did
So-
that come from?
It came from, here's the medial or the bigger inside, here's the lateral or the smaller outside ridge, and it came from right here. So this is exactly the bone bed that it came off of, which is right here on this. So it went from the outside here, and where it kind of landed on the outside. So, and then if we look at this front to back, it's sitting right here.
Oh, so this way it looks like a narrow sliver, but it's actually a little wide.
It was wider,
than that.
yeah. But that's
But it
okay.
looks like there's still a little hairline bone bed still there, right?
Mm-hmm. And so that's what we debrided. So it's hard to see it on this because the ridge where it came off of is overlying the rest of the bone, so you don't see it very well because its fracture bed is right off here.
So then, when you put the thrombin glue, did you put it over there?
Mhm.
Over on that?
Yeah, so what we did was we removed this, flushed the joint out, and then we flushed all the fluid out of the joint with gas arthroscopy. So you kind of dry it out, and then we mix the PRP with thrombin, which immediately forms a gel. So it's like those epoxies almost, those epoxy glues, like both are liquid, but when you mix them, within about 5 to 10 seconds, it's a solid gel. And the goal behind that is that it stays more in place. The tough thing is you know, when we inject it, we do put it in place, but then it's always possible that it can get squished and moved around. So that's why we do the gas arthroscopy, inject it, try and move the joint capsule and make sure that it's not adhered to the joint capsule so that then we kind of know it's sticking there. And so that's what we did on her. And